to a special question answer webinar for a Monday. The topic today is the itch, and as always, our CEO Colette Dane is here to host the webinar, and we're delighted today to welcome Dr. Vinod. I hope I get this pronunciation right. Is it Hegade?
Hegade.
Hegade. My apologies.
Colette is right. Hegade.
Always right. I'm old. I've got the privilege.
Anyway, I hope you have an enjoyable and informative session, and I will catch up with you at the end. Thank you very much.
Thank you, Alan. Thank you. Vinod, lovely to see you again. I'm sorry that you're having to work harder with the COVID thing. It always distresses me because you're so good, you doctors, giving us your time. We've got someone saying hello, everybody. Thank you for having us to your event, Jean. So today, everybody, welcome and thank you for joining us. We are going to be talking about the itch and asking questions. However, if there's something else you want to know, we're more than happy about that, aren't we, Vinod?
Yeah.
PBC, because I think you're pretty up there with the best. I mean, you've sat all your exam, passed in flying colours. It's more I can say for James Newberger, but never mind, moving on. So we'll happily answer questions, but in particular, the itch. Some people itch very badly. There's some people where it's controlled and some people don't itch. And we're keen to hear from all of you. If you want to go to our app and carry out surveys, the more data and statistics we have, the more information we can take back to pharma and to researchers, and the more they can help us. We know this is one of the major distressing symptoms of PBC, and we'll help you all that we can. That's for sure. I'm going to start before I ask any questions by saying to any of you out there who I find it really, really troublesome, go to the chemist and buy a huge bag of Epsom salts, biggest bag or bucket you can get, and have a nice bath in that if you can. Not everybody has baths. Rinse your hair in it, and it really does help. It's used in hospitals. It's very, very basic. But salt, as my granny says, is just, the gold of the earth. So I'm going to start. Be happy with that comment, Vinod?
Oh, absolutely. I was going to say, whatever helps, because there is no panacea for itch in PBC. People suffer with this symptom every now and then, and they will have their own way of dealing with it. Epsom salt, sometimes just taking a warm bath, wearing loose clothes. You will find your own way of dealing with it in a non-pharmacological way. So yeah, it's a trial and error, and you will find your own ways, and just do whatever helps.
We had, Bob Gish from the States come in last week doing that questions and answers, and I met Bob some time ago. He's a very good friend of the foundation, and he said that many of his patients found primrose oil capsules to be very helpful. So it's worth throwing out there, isn't it, for anybody to try. But give us your feedback. Tell us what you think and what works. Dietary as well. We know that people are talking about excluding various sugar things, which seems to help. So I know you've got the questions, but I'm going to say them out loud anyway for people out there. So the question is, if a person is taking rifampicin 300 milligrams twice a day, sertraline 25 milligrams, and gabapentin 600 milligrams for the itch, does that person stop the medication if they enter any study on the itch that may become available sometime next year? Now, of course, every study is different, but you've been involved in many, many studies.
It's a good question. Interested to see that, people are keen to participate in clinical trials, and that is very important for any patient with PBC. Seek out those studies that you may be able to participate, and I encourage all the members of the foundation to do that. To answer this specific question, as Colette said, every clinical trial is different. They have strict inclusion-exclusion criteria. Not all the trials ask you to stop your current itch medications, but majority do. Because you can imagine, if they're trying to study a new drug on itch, they want you to stop all your background medication. That includes rifampicin, sertraline, cholestyramine, whatever you're on. They do not want those medications to confound the results of the new drug. Like the 2 clinical trials that we have signed up in Leeds now, which will start in the next 3 to 6 months, both the trials do not want rifampicin as the drug. So if patient is already on it, but want to do the trial, they have to stop the rifampicin for at least 4 weeks. so that there's a washout period, so that this drug is out of your system, and then you participate in the trial. Either you take the placebo or the new drug. Yeah, every sponsor is different, every trial is different, but there are trials which will allow use of cholestyramine as and when needed, or antihistamines as and when needed. So yeah, you just have to speak to your study investigator, and they will tell you what the protocol is.
Okay, thank you. Just on the subject of rifampicin, so the next question, rifampicin said not to be so efficient if stopped and restarted. And this came up last week with somebody who had Helicobacter pylori. So had to come off everything and then went back on it, and she felt that it wasn't working as well. But I don't know anything about this.
That's new to me as well. We have started rifampicin on patients. Then we stopped the drug because their liver enzymes have gone up. Because one of the major problems with the rifampicin is you have to monitor your liver function tests. That's a blood test on a regular basis. If your liver enzymes are rising, we clinicians may stop the rifampicin for a few weeks. But when we restart it, I have not seen loss of response. I have not seen much difference in the efficacy of the drug, stopping and restarting. But there may be some patients who may not have received so much effectiveness, when they have stopped and restarted it. But there is no scientific reason for that. It should work even after restarting, for a period of time.
Yeah.
So when the ALT comes down, we have restarted it, and we started a lower dose and take it up, and it has worked in 9 out of 10 cases.
That's interesting. I'm delighted to know that it's even the drugs there for TB. I think it's just an amazing. My granny was 33 and died of TB with 6 children. So I'm delighted that these things are available for people for whatever the use, I have to say.
Yeah, and can I just say, rifampicin has the best evidence, and we have a very low threshold in Leeds to start rifampicin. Anybody who is itchy, we try them on cholestyramine or cholesterol or cholesevelam for a month or 6 weeks. If there's no response, we put them on rifampicin. In the hepatology, on the liver community, there is a very strong faith about rifampicin. It's got the best evidence, and it's very effective. But there's a way to do it. You need to start with a small dose, build up the dose, and you have to monitor with a blood test every 2 weeks. Because liver enzymes can go up.
That's interesting. It's 2 weeks. There's rain battering in on the window there. I'm awfully glad I'm inside. So the next question is cholestyramine, cholesterol, which I haven't heard of, better for the itch than gabapentin? That's a bit individual, isn't it not?
I wouldn't say better than, because there is never a head-to-head trial or a study with these medications. In fact, there are 6 or 7 itch medications. None of them have been tried against each other. There is not a trial to say we'll randomize 50 patients into cholestyramine group and gabapentin group. Only then you will know which one is better. But that trial has never been done. Cholestyramine or cholesterol is the first-line medication that's endorsed by all the guidelines. So we use them as the first-line therapy. Gabapentin is used much lower down. I haven't used gabapentin much, not as much as cholestyramine. So I wouldn't say cholestyramine is better than gabapentin, but it certainly is our first-line medication for itch in PBC. So try cholestyramine sachets for a month. If they're not helping, you can go on cholesevelam tablets. If they're not helping, then you stop them and go on rifampicin. Then we give sertraline and other medications. And those other medications include gabapentin and other things.
And is it fair to, I think perhaps it's good to comment at this point about how cholestyramine is taken, because we know it's got to be taken away from any other medication you're taking. But is it not the case it's got to be taken before and after food, in the morning, and even though the itches at night?
Absolutely. There is absolutely a fair point, Colette. Cholestyramine has to be taken in the morning, preferably on empty stomach, because the bile acids are produced overnight. They are stored in the gallbladder overnight. And when we take our first meal of the day or breakfast, the gallbladder contracts and spills the bile acids into our gut. And the idea of cholestyramine taking in the morning is that when you take cholestyramine, it goes into your gut, it goes into your bowel, and it binds to those bile acids. And it's those bile acids, which some of them are can cause itch. So the cholestyramine binds to those bile acids and reduces the itch. That is the idea. So preferably take in the morning. And you have to space all other medications at least 2 hours, sometimes 4 hours away from the cholestyramine. What does that mean? You take cholestyramine, say 7:30 or 7 o'clock in the morning, and whatever you're taking, if you're taking aspirin or your blood pressure medications or diabetic medications, you take them much later in the day, like 10 o'clock or 11 o'clock in the morning. That's important, because otherwise the cholestyramine will bind to some of these medications as well, and it will reduce the efficacy of those drugs. So it's important.
Right, that's really, really helpful. So thank you. The next question, my October hepatology appointment had been cancelled with no forward appointment offered, so I'm unable to discuss my medication with my own specialist. As I was out of the UK, I had to change my medication when I could not buy cholestyramine, so substituted with gabapentin. I'm relatively well and able to cope with, but due to COVID, my self-enforced stay for 17 months, or when a 3-week holiday only was booked March last year, I've not seen a doctor since December 2019. Although I did arrange for blood tests whilst away, from what I could understand, they were within range. So this person's gone on a holiday and got trapped because of COVID and has not seen anybody, but her blood seemed to be okay. I mean, I don't know if many of you heard when we first came on line there that Vinod was saying in his neck of the woods in Leeds that, there's more COVID and the hepatologists are having to help out with the COVID wars. But I don't see that, and you tell me if you think this is right or wrong, that this person can't actually drop a wee email to our consultant.
Yeah.
Would that be in line to do so?
Yeah, I mean, increasingly, this is a problem, isn't it? Unfortunately, patients with chronic diseases are getting trapped with this COVID pandemic. Appointments are being missed. The appointments are getting cancelled. People who need a clinical review are not getting their consultants or registrar. So there are lots of people out there who are suffering, and it's a sad thing. Increasingly, most of the clinic consultations are via telephone nowadays. So whether you are abroad or away from your usual local hospital, you still will be able to conduct a telephone consultation with your gastroenterologist or a hepatologist. We are certainly doing that in Leeds. We have stopped asking patients to come to the clinic physically, so we just speak to them on the phone. We also have access to the Attend Anywhere, which is the NHS's video consultation. So if you are asked to sign up for Attend Anywhere clinic consultation, please do, because you can do this from your smartphone. You just need to have a camera, or you can do it from your MacBook or computer at home. So you are going to do a video consultation like you're doing now with me, with your consultant. So increasingly, those technologies are being used by most of the hospitals. Regarding this specific person, I don't think they have suffered in the way that those 12 months of no appointment, nothing bad has happened to this person. Their blood tests are relatively stable. They have said they are coping well with their symptoms. Gabapentin seems to have helped their itch, so which is good. And in majority of the cases, PBC, in a span of 12 months, PBC doesn't progress that rapidly in majority of the cases. PBC is a very slowly progressive disease. It takes years, if not decades, to develop into a major problem. But yes, once a year, most patients need a review with their gastroenterologist or a liver consultant. And if it is not possible to do it physically face-to-face, please do it over the telephone or via video consultation.
Yeah. So don't feel shy about dropping your consultant an email, and let your GP know you've done it, but just wait a wee bit for a reply, given the demands on the doctors and nurses and staff at the moment. And it's also fair to say as well, from the patient point of view, that quite a lot of people, of our members, have said to me on the phone, they actually don't want to go to hospital. Now, I know it's not for everybody, but they're happy not going to the hospital and having something like this for a multitude of reasons, COVID being the primary reason. But of course, there's parking and all the other, and traveling. Who wants to travel on tubes and buses when there's COVID around? So I'm saying to everybody, don't think of it as such a negative thing. And when you do have a consultation with your hepatologist, and remember, time is tight, so have ready your list of medications, how much you take, and what strains. Not that, oh, that wee blue pill, what's it called again? Have your list ready, because your consultant won't know what medication you're taking. He's got no right to assume it's the same as last time. You could have, had developed arthritis or whatever. So he'll want to know what medications, and also if anything's changed. Anything different, then have that on your wee list, and that will help your meeting with your doctor, be it on the phone or the video, and even if you see them in person. I think time is precious, so let's use it as efficiently as we can, and we can do a bit as patients, can't we?
Absolutely. And on that note, I would like to urge your members to not to ignore the oral contraceptive pills. If you are taking them, please mention them to your doctors. Because there are interactions with oral contraceptive pills. For example, rifampicin. Rifampicin and oral contraceptive pills don't go along together. Okay? Wow. Rifampicin reduces the efficacy of oral contraceptive pill. Okay? So if you are taking pills, if you're in that reproductive age group, and you're taking rifampicin, and if you don't tell your clinician that you are taking contraceptive pills, we wouldn't know. Okay? Because we don't prescribe them. Your GP may be prescribing them. So please don't assume that your hospital doctor knows everything about your medications, because we don't. So at every clinic consultation, it's important to go through your medications. And rifampicin in particular, as I said, it's a great drug for itch, but it has got a number of issues. One issue is the liver enzymes. The other issue is it reduces the effectiveness of your contraceptive pills. So if you become pregnant while you're taking if you become pregnant, it's an issue. I mean, it's great to be pregnant for majority of the women, but some women don't want to be pregnant. And it comes as a shock to them. Yeah. Why am I pregnant when I'm taking contraceptive pills? Well, because the contraceptive pill didn't work because of rifampicin.
Do you know, Vinod, I've never heard that before. That's amazing.
It's a real story, Colette. Obviously, I'm not at liberty to divulge any information, but we have had an issue recently.
Well, I think we'll get that on one of our Mythbusters, one of our tiles that Jenna does for us. That is a fabulous little nugget there. Yeah. Wow. As I say, it doesn't affect me, but never mind.
Yeah.
So this is a really good question we've got now, Vinod.
Yeah.
So the person says, could I ask what the PBC itch might feel like? Because I have prickles and tickles, like something crawling on me or a single hair touching, and I also have pinpricks or being bitten by something very small. The itch moves around and is everywhere, but not necessarily at the same time. I also get the pinprick sensation in my eyeballs, my throat, and it's not related to the dry eyes, dry mouth I also experience. That's a fantastic question.
It is. It's a very difficult question as well to answer, because it's a very subjective symptom. I don't think there is any textbook description of a classical PBC's itch. There are at least 4 or 5 large studies trying to characterize the symptom from patient's point of view. So when I was writing my PhD thesis, I had to look into that. If you ask 100 people with PBC who experience itch to describe it, you will come up with 100 different ways of description. So there is no one way of describing the itch. Obviously, I don't have PBC. I'm not experienced it, so I don't have any personal experience to share with you. But you will agree with me that it's a very subjective symptom. But if you look at the textbooks, or if you look at these literatures who have described this symptom, for example, in 2008, there was a very large study from America who asked their 250 members of PBC patients to describe it. There were at least 20 different descriptions. Wow. Okay? They tried to categorize into some kind of categories. And I'm happy to share that paper with you. And
yes, I would quite like to see that.
Yeah. It's fascinating. It's made its way into my thesis, obviously, and I was trying to read that in preparation for this question. It's difficult. Most people describe it as a kind of a deep irritant. It's something there deep in their skin, which they're trying to scratch and pluck out, but they can't. And they're scratching, and scratching doesn't help. And some people are scratching so bad that their skin breaks or they bleed from the skin. Classically, it affects the palms of the feet and the palms of the hands and soles of the feet. But it can very quickly become generalized. It can become, it can affect any part of the body. I don't think there is any exemption anywhere. It can affect chest, torso, abdomen, legs, but it's usually peripheral, as in fingers, palms, and your feet. Some people describe itch deep within the ear canal. We've had that question, haven't we, Colette, before?
Yeah, sure.
So, in the right context, yes, this symptom should be considered as part of PBC. But remember, there are a number of other conditions that can cause itching. PBC is not just one condition. There are at least 10 or 20 different skin conditions, dermatological causes of itch. So those need to be excluded as well. So if you're not sure whether this itch is due to PBC or not, speak to your doctor, speak to your gastroenterologist. They may refer you to a skin specialist, because we cannot assume everything is due to PBC. It may be, but it's important not to miss other conditions.
It is. I mean, we hear things like spiders crawling up the skin, but we also hear, and this one struck a chord with me, about needles being pushed up from inside the skin. And I'm going to tell you a little story, and I hope you all read something into this, and it really confirms what Vinod is saying. I mean, some years ago, I had this experience in my arms and hands, and I have heard that from people with PBC, and it was like big large needles being pushed up in my skin, and nobody could get to the bottom of what it was, and they were left with, well, maybe it's PBC, we don't know. And I have a friend she's just recently retired a virologist, and I was telling her. So she said, well, is anything new? Your soap powder? I said, no. She says, anything you can think of, your lipstick, your makeup. And I said, well, funnily enough, I have a new anti-wrinkle face cream. She said, go and get it, let me have a look. Now, I wouldn't understand any of the chemicals that were written on this jar, but there was antifreeze in this cream. Antifreeze. So she said, take it back to the shop, tell them that is over the amount that's safe, which I did, and it was withdrawn. I stopped using it, and the sensation went away. So that really validates your point. You really, yes, PBC is a biggie, but look at a number of, don't just be tunnel visioned on it. And as it was, I didn't need an anti-wrinkle cream. Sure. Could you imagine antifreeze and an anti-wrinkle?
Yeah, there are loads of chemicals there. The contact dermatitis is called. That's a medical word for any of these chemicals causing irritation to the skin. Contact dermatitis or allergic dermatitis. That is far more common than PBC, right? So, as Colette said, you need to look at. Have you used any new soaps or new detergents, new perfume, new body spray? Those things need to be ruled out. But if you're not sure, you need to be seen by a skin specialist. And if they say this is not a dermatological cause, then we can say, okay, this is all due to PBC.
Because we do get other things. So this next one says, I'm not a liver patient, but the soles of my feet itch at night. I've read this could be caused by numerous things like allergies, dry skin, but also could be a liver disorder. Should I have checked?
Yes, that covers into, that leads from what we've discussed now. So absolutely, soles of the feet, as I said, are a classical site for itching in PBC. And if this person has not had a blood test, I would say get a blood test for your liver enzymes or liver blood test and the PBC antibody test. It's a simple blood test. Within one sample, you can check the antibody as well as the liver enzymes. From a rule out the diagnosis of PBC.
It's worth ruling out, absolutely. I've got a question here. I know this is who this is from. She would go on any trial for PBC. I'm sure she's been on many. Is glycin and gliment the same trial? Glycin and gliment, Glimment.
Yeah, I need to look it up because these trials have some fancy names.
So they're attending Nottingham. That's is it Queen? What's the Nottingham Hospital? Queen's
Medical Center. Yeah. So what are the trials again? GLISTEN
is one, glycin, and then gliment, GLIMME
Yeah, so Gliston, I'm just looking up now because I can't remember all these trials, Colette. So yeah, Gliston trial, let's see what the drug is. So it is a trial for itch, that's for sure. Yeah, it's a linerixibat, which is the, is that GSK's drug?
I think it is.
Yeah, I think it is. So that is the drug which blocks your bile acid from your enterohepatic circulation. Basically, this drug, when you take it by mouth, it binds the bile acids in your small bowel, something similar to Questran or the cholestyramine. So linerixibat is the Gliston trial. Okay, what's the other one?
Glimmer, G-L-I-M-M.
Oh, Glimmer. Yeah, Glimmer definitely is the same drug.
Right.
Yes, to answer the question, yes, both are similar drugs. Glimmer was probably a phase 3 trial, wasn't it? Glimmer trial.
Yeah, I think that's right. I mean, time goes by, doesn't it?
Yeah. So give me 1 second. So yeah. Yes, the Glimmer and the Gliston are same. You need to check who is sponsoring these trials.
The GSK trials, right?
Yeah, GSK.
Yeah, we know there's about to be more presentations about the itch. You know Cynthia Levy in the States?
Yeah.
Cynthia's been in touch with us, and she's working very hard, just so you are on this side of the water. And sure. She's very involved in the itch. And
yeah. I mean, the linerixibat was my PhD. We did a phase 2 trial of that in Newcastle. And that led, because that was a positive study, and that led to the drug being developed into later phases of the trial now. So we did a smaller phase 2 trial between Newcastle and Birmingham of 22 patients. It was a positive trial. It got published in Lancet. And now the drug is being taken forward into a much larger study, multi-center study. I think Glimmer study, they were looking at 130 or 150 patients with itch. It probably is done very well now in terms of recruitment, and we should be getting the results very soon. And if that drug becomes available, it's a great thing for PBC patients, because, as I said, at the moment we don't have effective drugs other than few like Rifampicin. So we really need better drugs. We need new drugs for treating itch.
As you know, Robert has just left the foundation. We've got Chris coming into the foundation, and Robert and now Chris has been working hugely with pharma.
Yeah.
And we're kind of getting a lot of contact from pharma and itch trials.
Yes.
And so Chris and I met up with someone who was over on holiday from the States, who works for a company. They're coming here in January, and they're going to be working with Prof. Jones and I think 4 or 5 other centres. But there seems to be an awful lot of attention on the itch, which is hugely heartening. I mean, do you want to tell us a wee bit more about what you think might be due, or do you know what's out there, or what's coming down there?
Absolutely. I mean, it's high time that the symptom of PBC is given its due importance, you know.
Yeah.
So far, the pharmaceutical industry was chasing the biochemistry or the liver blood test. If they come up with a drug that reduces your alkaline phosphatase, that's great, you know. But of course, it's important to reduce your alkaline phosphatase in BPC and give reduction of the severity of the disease. But it's also important to give a quality of life to the patient. This is a chronic condition. This is a lifelong condition, okay? And if you have symptom of itch, which you are suffering with almost every day, does it matter to you what your alkaline phosphatase is? No. What matters to you is, can I sleep at night without itch? And sadly, nobody was focusing on this. But now, as we understand more and more about itch, at least in the last 5 to 8 years, more and more drug companies are coming forward with their molecule. And they want the help of PBC Foundation. They want the help of, you know, experts like us to run the trials, which is great, actually, because we need to find out new drugs. So at the moment, what we have, at least there are 3 drugs coming up. One is these ileal bile acid inhibitors, which is a broad name for this, which is a tablet drug. You take it and it binds to the bile acids and reduces the itch, and linerixibat is one of them. There is another compound which is like a opioid agonist, and that blocks your opioid receptors, and that also shown to improve your itch in animal models. So that drug is coming up. The third one is in a very primitive stage now. There is a new bile acid receptor they have found out. It's called MPRGX4 or something called that. Something like that. And that those companies have come to us a month ago saying that we want to trial this drug in a very early phase trial. Would you be interested? So yes, there may be more and more things coming, but it's great. I'm excited because as I said, in 2013, when I was doing PhD on itch, there were no companies, there were no new drug companies knocking on our doors. Now there are at least 5 or 6 companies that want to use this symptom. They have understood the seriousness of this symptom, and it's great for the patients because in the next 10 years, we may have 3 or 4 new drugs. Which is great for clinicians because it's frustrating for the patient, it's frustrating for the clinicians that we don't have anything to treat you with. When you come to my clinic and say, I'm itching all over, right? And I've tried every drug that I have in my kitty, and I've used everything, then I'm frustrated. I have nothing else to offer you. And you will look at me as if you are my doctor. You're supposed to help me.
Fix it,
fix it. But we can't because we have nothing else to offer you.
One of the companies that contacted Chris and I, and they were explaining that their drug had been trialled on kidney disease. I didn't realise an itch comes with kidney disease as well. And it was hugely successful, and there seems to be a bit of excitement around this. And one to others. So there's a lot going on, which is hugely encouraging, and I hope people out there who's watching it now live and later on, you will take heart from that. Somebody's actually sent a question, and for the small amount of people that these medications do not work, what would you recommend? I mean, that's just the kind of thing that you've been talking about.
Unfortunately, 10% of PBC patients who have itch have it as a very severe itch. So what we call as a refractory itch, which means you have not responded to any of the standard medications. And those group are less than 10%. For those group of patients, there are only 2 options. Either you take part in a clinical trial, or in terms of definitive treatment, the cure is liver transplantation. So if you have not responded to any medications, and if your itch is getting worse, we can assess you for liver transplantation. And if you are listed for liver transplantation, while you're on the liver transplant waiting list, we could offer you other treatments like phototherapy. We can offer you nasobiliary drainage. We can offer you plasma exchange.
Yeah, I've heard about this. Yes, it's not that common, is it?
It's not that common. It's not available everywhere. It's definitely available in specialist centers. We in Leeds have access to plasmapheresis. It's given by the hematologist or specialist in blood disease. It's like a dialysis unit. So you go there and they give you plasma, basically 3 or 4 bags of plasma in your body, and that is supposed to reduce the itch, and that's done on a twice weekly basis, and they assess the response. So it's good. There is some good evidence for plasma exchange. It works. I've certainly referred 2 or 3 patients in the last couple of years. They have benefited from it. But it's not the cure. Okay, plasma exchange, the disadvantage is you have to come into the hospital. It's not a tablet. You have to physically come into the hospital to have this session. Each session is about 1 hour, 1.5 hours, and you go home and you come back again after a few days. Phototherapy is also available in most hospitals, even in smaller hospitals.
Which is phototherapy? Did you say?
Phototherapy, yeah. Phototherapy is like your narrowband phototherapy. It's not like your sunbed, right? It's not same as your sunbed. The light that is used in sunbed and phototherapy is completely different. The wavelength of the light is different. Phototherapy is a medical treatment. So if you are very itchy and you are not responding to any medications, speak to your doctor. They may refer you to phototherapy. And finally, nasobiliary drainage is physically where we do a camera test, we do an endoscopy to put a fine tube in your bile duct and bring it out of your stomach and then into the nose, and you will have a tube coming out of your nose, and you can leave that tube in for about a couple of weeks, and from the end of the tube we can aspirate or drain bile. So that's pretty invasive, but it's available for patients who are very itchy, they're very severely itchy, and they have not responded to any medications.
Yeah,
all these 3 treatments are available in Leeds. They will be available in the major or bigger hospitals around where you live.
Yeah, it just shows that, some people can just come to the end of the tether, can't they? I'm glad it's been taken more seriously now, and there's a lot of work. So have heart, everybody. I've got a question here. I'm waiting to see the optician, so I'm not reading very well, right? I sat on my glasses, so let's not worry about that. I live in Dorset, so is there any in my area that could go and see? And I don't know if you mean research. I take it she means research in Dorset.
So the person is based in Dorset and they want to see somebody regarding clinical trials.
Well, I assume it's clinical trials. It's just a shortened sentence. It just says, I live in Dorset. Is there any in my area that I could go and see? So I'm assuming it's clinical trials. And whoever's out there, whoever sent this in, please correct me if I've got this wrong.
Yeah, it's interesting, isn't it, Colette? There was a time that me, you, and Robert were talking about setting up a visual kind of UK map so that the members can benefit. Yeah. And if they can just go on PBC Foundation and they click on the UK map and click on, say, for example, Dorset or whichever the nearest hospitals, and they can open up a little window and that tells you the name of the consultant, name of the clinical nurse specialist. I don't know where that project is with, but that
I think it got buried. Let's get back on it. I like the idea of that.
Because this question keeps coming up. For example, this person is probably assuming I know somebody in Dorset whom I can recommend and say, this XYZ, Mr. Smith or Dr. Smith is there in Dorset, and you can speak to them. Unfortunately, we don't, right? UK is not a big country, but we don't have a knowledge about who is in Dorset or Exeter or Southend or, say, for example, in Aberdeen. Who are the clinicians who are experts in PBC? Who are the nurse specialists working there? So that we can put you guys in touch with them whenever these questions come up. And my dream project was that with the help of Foundation, we come up with a visual map of the UK with all the centers, pointed out so that anybody can click. For example, somebody clicks on Leeds, all right? And suddenly a box opens, St. James's Hospital, PBC experts are Dr. Vinod Hegade, Dr. Rebecca Jones, Dr. Ramu Chimakurti, those 3 consultants, and we have a common email. Similarly, somebody sitting in Hull clicks on that. They don't know who to contact. They can click on it, and there they get the names of the specialists. How cool will that be? Yeah.
Right. Well, consider it halfway down the path, okay? You know what I'm like when I decide to do something, but we will get on that because, and I suppose as well, with COVID being here for this length of time and what you were saying, the most being asked of the doctors.
It can't be that difficult to do, Colette, because you have such a network. Your network is amazing, and you probably know 50% of the clinicians up and down the country. You just need to put it on the map, so that the patients can benefit.
Yeah, we need to get that Newburger chappie who's talking about retirement, all the rest of it. We'll need to get him onto it. Bless him. Yeah. Somebody's saying, would a light box be the same as phototherapy?
No, definitely not. It's I think that person is referring to sunbed, I'm assuming, but do not assume the light box or the sunbed are same as phototherapy. No, because phototherapy is a medical intervention. The lights, the wavelength of the light that is used in these treatments is different to what you get, in a sunbed. So it's not the same. It won't work if you just treat yourself with these light boxes or sunbed. No, it has to be given by a medical profession. It's given by a nurse specialist in skin department or dermatology department. And they use it for patients with psoriasis. People who have psoriasis, have the skin lesions, they get phototherapy all the time. So something similar is also used for PBC patients as well with itching. So please.
So there's a difference. Yeah, because they have these light boxes as well for SAD syndrome, don't they?
Correct.
Yeah.
There are some light treatments that you can go on the eyes. Some for some diseases, people put some special light on the eyes as well, but that's different. Here we're talking about you entering a sunbed-like thing, like a cubicle, and you close the door, or sometimes you may have to lie down in a box and close the door, and they give you 2 to 3 minutes of intense light therapy, which basically covers the whole part of your body. That's only for 2 or 3 minutes. The treatment is only for a few minutes, but if it is effective and it reduces the symptoms, it gives you relief for about a week or 10 days, and you come back again for another session.
That's really, really helpful to know. Somebody's actually, we've covered this, but I think rifampicin is an antibiotic, is it not? Yes, it's for TB.
Yeah.
This person says all antibiotics have the same effect on the contraceptive pill?
No, they don't. Not all of them have same effect. For example, penicillins that you may get for your urine infection or throat infection, like amoxicillin or doxycycline, those kind of antibiotics may not have the same effect on contraceptive pills. But it's important to check with your doctor, because it's very easy to check the interactions on a website that we doctors have access to. Within 2 minutes, I can check if one drug is interacting with other drug. So rifampicin is definitely a big problem if you are taking contraceptive pills. There are other antibiotics, other anti-epileptic drugs, which are also potential interactions with contraceptive pills. Therefore, if you are a young PBC patient in the reproductive age group, and if you are taking contraceptive pill, please make sure that your doctor or the nurse specialist knows about it, so that they can check with the interactions between rifampicin and contraceptive pill. And the dose needs to be adjusted, or they need to be taken separately. You take rifampicin in the morning, take contraceptive pills later in the day, or vice versa. Plus, if you are taking rifampicin for itch, and if you're taking contraceptive pills, we advise you to use another method of contraception if you don't want to become pregnant. We may ask you to use barrier methods, use condoms. Your partner may have to use condom for the duration that you are taking rifampicin, because it is a major issue. You want to become pregnant.
You learn something every day. Every day's a school day, isn't it?
It is.
Jen is on the screen here. She says, does it have anything to do with the gut? I know, Jen, I was coming to this. You preempted me. And I've mentioned this to you before. She says, I've changed my diet and focused on pre and probiotics. And over time, my very severe itch is gone, only comes back if I'm given antibiotics. Jen is a small number of people, and I've mentioned this to you before, which I find hugely interesting, that she noticed various things in her diet. When she had them, the itch was there. So she had to work away. She has her own company, and she had to work away and had to eat just what was around. The itch came back. She goes back home, back to her way of eating. She's a very healthy eater. She grows things. She's very organic. She's very mindful. And her itch disappears. Now we have other members who are saying the same thing, Vinod. So I take your point about antibiotics, Jen, so we'll answer that. But we can't dismiss this food thing, really, can we?
No, we can't. The question is a superior question. It's a fantastic question. I wish we had an answer. In 2021, sitting here today, I do not think we have an answer to this question, Jen. Does itch have anything to do with the gut? We asked this question, and we did a small study as part of my PhD. We took stool samples from PBC patients with itch and compared the stool samples with those who don't have itch, right? In those small study, we did not see much difference, right? If you're talking about the gut bacteria, now you may or may not be aware, every disease is being studied with respect to gut bacteria. If you just Google gut microbiota and see how many studies, not just PBC, diabetes, dementia, all kinds of disease are obesity, everything is being linked to gut microbiota now. There is probably a major role a gut microbiota are playing in PBC, right? There probably is a set of bacteria in our gut, which, especially in PBC patients, which is doing something to cause the itch. What it is, we don't know at the moment. but people are studying it. I studied a little bit of it. My study was a negative thing. It doesn't mean that it doesn't exist, but it needs a much bigger study. We need to understand what is it that the gut composition of PBC patient with itch, is it different to somebody who doesn't have PBC, or is it different to somebody who has PBC but no itch? You know what I mean?
Mm-hmm.
I like this question because we asked the same question 7 years ago. We did something, we couldn't find anything. We even published the paper as a negative paper. But to answer this question, I don't know. I don't know, is itch got anything to do with the gut? Now, diet, I don't recommend any special diet to my PBC patients with itch because there is nothing prescriptive that I can say that evidence has shown this, because there is no evidence for this. Like clinicians like me practice evidence-based medicine. Whatever we tell our patients has to be backed by some literature evidence, some scientific reason. If I don't have a scientific evidence to say, don't eat this, don't drink this, don't eat more of this, I should be saying that based on some evidence. Yeah, I can't just willy-nilly say, take this probiotics, take this prebiotics, they'll do wonderful to you. I'll be lying if I do that. But again, if people out there are doing it, for example, Jen, if she's taking antibiotics for something else, and if she finds her itch is better, then that's her experience, isn't it? We cannot dismiss that. That's her experience. But we cannot use that and use that information to rest of the patients.
No. But what we can do, and I've discussed this with James when we get ourselves organised, and when we get staff embedded in and what have you, is looking at our own questionnaire for our members, and we've got thousands of them, putting together a small questionnaire, and we can word it, carefully. But let's look a wee bit closer into this, because I've said to you before. I mean, the people that say to me, "Well, I gave up chocolate and put on weight, and then I thought, Christmas, my itch went away. Christmas time, I was like, I had some chocolate, my itch came back." So it is their own experience, but it maybe is worth a small
Absolutely.
study.
Absolutely. Again, your foundation is well placed to do that kind of study, Colette, because you have access to thousands of your members. Out of those, at least say 100 people are suffering with severe itch.
Yeah.
And if you look at the diet questionnaire, that would be a fantastic study. I'm telling you, because there is nothing out there in the scientific literature, I can tell you for sure. There's nothing to tell us what is the relationship between diet and itching. So if we can come together and do a study with the help of James and you and other people, and do a questionnaire-based study and try to tease out, is there anything that diet and link to itch? It'll be a good one.
Well, let's just think about that. There's two things on my list now: is study and map, right?
Yes.
But I think now, we've got Chris in. It's been a big change. Robert did a lot of work, and Chris had a lot to take over. But that's something I'm having a meeting with Chris tomorrow, and I'm sure he'd be delighted to take part in that and help us put all that together. So I'll come back to you on that one. Got a question here. Funnily enough, I had a helpline call last week asking the same thing. Vinod, what are your feelings on naltrexone for the itch? My provider is considering this now, and I'm concerned about taking this class of medication.
Yeah, very good question. There has to be a good reason that your doctor has recommended that. It is there in the guidelines. It is there in the treatment pathway. I have given it to some people, but it is not a nice drug, naltrexone. It has got side effects. It basically blocks your opioid receptors in your body, in your brain. So the side effect profile of this naltrexone is not very good. If you're taking it, I would say take it with a small dose. Start at 12.5 milligrams once a day and see how you feel. And then if you gradually increase the dose, you may be able to tolerate it better. So it starts at 12.5 milligrams once a day. You double it to 25 milligrams after a few days. Then you'd go up to 37.5, then to 50, then to 100. Personal experience with it, my patients have come back and said, I don't like it. It just gives them horrible side effects of disorientation, sleepiness, It does something weird to your body. It changes your blood pressure up and down. So most people don't like it. In Leeds, we have very rarely used it. I've used it when I was in Newcastle. In Leeds, naltrexone. By the time you're needing naltrexone, you know that your itch is not responding, and you need to look at either liver transplantation or invasive treatments that I explained earlier. But if you want to try it, if this person wants to try it, I would not discourage them. Use it, but be aware of the potential side effects. Start at a small dose and take it for a month. My rule with itch and treatment is every medication should be given a trial of 4 weeks, right? I have a 4-week rule. I recommend one drug at a time. Use it for 4 weeks. If it is not helping, move on to something else.
I'm glad you mentioned this, because I got a helpline call when I was on holiday last week. I found it quite distressing. A lady up in the north of Scotland had PBC, and her gastroenterologist was of the mind, just to give you an idea of his level of education about PBC, well, your liver function is looking better, you can reduce your urso, which I've actually referred to guidelines and said, no, do not do that. She's asked for rifampicin for the itch because she couldn't get the cholestyramine. She went to her GP. Her GP actually hung up the phone. She said, rifampicin is for tuberculosis, it is not for PBC. And I want you to say this on live camera now, that is not the case. Would you please, for this lady up in Murray?
Absolutely. And I'm very sorry to this person who has been given a wrong information by her GP.
Yeah.
It's completely, well, without using any expletives, it's a wrong thing to say. Rifampicin is definitely used in PBC patients with itch. As I said earlier, it's got one of the best evidence for, and we use it very regularly. So yeah, unfortunately, Colette, you're right. There are lots of gastroenterologists out there, lots of GPs out there who have not come across PBC, who very rarely see PBC patients. So their knowledge is not up to date. And what can we do about that? Yeah.
Well, I think we reserve the right as patients to say to them, here are the guidelines, and download them.
Yes, absolutely. And you need to challenge them. And I don't mind a patient comes to me and challenges me, saying that, Dr. Hegade, sorry, so-and-so you said is wrong, or so-and-so is available, but you're not giving me. So I encourage all your members to challenge your clinicians. Your lay version of guidelines on PBC is excellent. I think every PBC patient should have that copy. It's about 8 pages long. And the information out there in those 8 pages is amazing. And you read that. And if your GP is not giving you the treatment that's recommended by the guidelines, you need to challenge the GP and say, I'm sorry, can you please refer me to a specialist who knows about PBC?
Absolutely.
You deserve that. And don't suffer in silence.
No. And I'm here behind you. If you had the intense itch when first diagnosed 17 years ago and cholestyramine worked for the itch, can the itch return? So I'm assuming this person hasn't had the itch for 17 years.
Yeah, it's again a very good question. It's absolutely, it can return. It can happen anytime.
Yeah.
It can wax and wane, which basically means you may get itch for a few days very badly. You take cholestyramine for a couple of days or a week, it goes away. And you stop your cholestyramine, and the itch doesn't come back for months or even years. So again, that bit we don't fully understand, but it is well documented, well reported. So not everybody suffers the itch every day of the week, every week of the month. So there is huge variation in the symptom. So if you are suffering itch maybe a few days in a year, consider yourself lucky.
Yeah.
Okay, because it's not too bad. Because there are people out there who are suffering with itch every day.
Oh, I know.
That's a horrible symptom. I've told this story once on this foundation webinar, where when I was doing a research, a lady who was participating in a clinical trial, who was about to participate in a clinical trial, her itch was so bad that 7 o'clock in the evening, she contemplated slashing her wrist with a knife, right? She wanted to end her life because her itch was driving her absolutely mad. And we got a call from her husband, desperately trying to get some help. And we immediately admitted her to hospital, right? To help her. to give her nasopharyngeal drainage, to give her phototherapy, whatever we could do to bring her itch down. So when it is bad, it is seriously, it's really, really bad. It drives people to madness. It drives people to suicide.
It has, absolutely.
So
call out for help. Phone me. Just phone. Don't.
But on the other hand, if you're not suffering with such an extreme form of itch, consider yourself lucky.
Yeah. We've got I've got a last question here from Jean. I have a problem with antihistamine and antibiotics. Is there any rifampicin or cholestyramine? Are there any in rifampicin or cholestyramine? I think what Jean's saying.
I have a problem with antihistamine. Okay. Antihistamines are not recommended for itching. So if you don't like them or if you have not tolerated them, don't take them. I give antihistamines as a sedative. Okay. Only for people who have severe itching at night, you can take a small dose of antihistamine like chlorpheniramine just to give some nighttime sedation, just some kind of respite. Even if you sleep for a few hours, you may feel better. But antihistamines per se don't affect anything. They do not give you relief from itching. In fact, the guidelines also say antihistamine should not be given as a routine treatment. But occasionally I have given them, especially patients are admitted with severe itching. They haven't slept for days because the itch is driving them. I give them chlorpheniramine or Piriton, 4 milligrams or 8 milligrams at night for sedation, only for a few days. Are there any in rifampicin or cholestyramine? No, rifampicin and cholestyramine do not contain antihistamine, if that's the question.
Yes, I think that is the question, yeah. And she's saying, I suffer every day and certainly believe your story. I've been there. Oh, bless you. Well, do you know, we're just on there, right? You've answered an amazing amount of questions, Vinod. Thank you so much. I am going to follow up with this stuff now that we've cleared our feet a bit. And I'll come back to you. I'll have a wee chat with James and we'll come back over the next few weeks. But I'm mindful of the situation in the hospital as well. And here's Alan to say thank you to us all.
He's appeared like a Santa.
Hello.
Everybody needs
another fantastic
Alan.
Session. Another great session.
Thank you.
So thank you very much, Vinod. That was very, very much appreciated. As always, very interesting, very informative. Thanks, Colette, for doing the needful.
You're welcome.
And we're back on Thursday at 2 o'clock with Dr. Alan Blunder from Boston in the US. So if you have any questions, if you can send them into the office, or as you do, send them in via Facebook. We look forward to receiving them. So once again, thank you very much to you both. I'm now going to go and close this down on Facebook and then come back and close this down live.
Vinod, thank you so much.
Thanks, Vinod. Nice seeing you again.
Vinod, let us know if we can help you.